Good to go, Tammy.
I think you're going to, okay, hold on one more time. Here we go.
I'm going to, hey, Tammy, real quick. Good afternoon. I would like to welcome everyone to our executive webcast series. Today's presentation is entitled Finding a Sustainable Business Model for Population Health, presented by Dr. Gallus, Chief Medical Officer for Utica Park Clinic, Hillcrest Healthcare System. In today's healthcare environment, the need to coexist in both the fee-for-service and value-based world is now becoming an operational necessity, but a strategic imperative. Utica Park was able to effectively use technology that works to identify gaps in care, engages patients while simultaneously improving quality and lowering downstream costs of care. Before we go ahead and start, I'd like to take a few minutes just to make sure everyone's familiar with the webinar control panel. First, you'll have a control panel on the very right-hand side of your screen. You can minimize and expand this panel by clicking the small red arrow in the upper left corner. Second, you can submit questions at any time during the presentation using the chat panel located near the bottom portion of the control panel. We really would like to hear from you and encourage you to ask questions as we present, and we'll take time to answer as many questions as we can during the Q&A at the very end of the presentation. If your question was not answered, we'll be sure to respond to you individually after the event. And finally, all registrants will receive a copy of the presentation as well as a link to the recording. Hillcrest Health System is part of Ardent Health Services, which consists of 6 hospitals in eastern Oklahoma, and includes a multi-specialty physician group practice of 250 employed physicians. Dr. Gallus has been with Hillcrest Healthcare System Utica Park Clinic since 1992 and serves in the internal medicine department, and will be presenting today during our webinar. Please note that all lines have been placed on mute to prevent any background noise. At this time, it is my pleasure to introduce to you Dr. Gallus.
Well, Guy, I appreciate the opportunity to share our story at Utica Park Clinic and Hillcrest Healthcare System about how we've begun to navigate the waters moving from that volume-based care to value-based care. And I would like to make this very clear. We're early in the phase of making this transition, but we've come a long ways. I would say that one of the things that we have discovered is how little we knew about providing value-based care. Our organization still is probably waist deep in volume-based care. 90+% of our revenue continues to come from volume-based care. But we've looked into the crystal ball and we've read the tarot cards, and I think we all agree that the time has come for value-based care, and we understand and expect that our revenues will continue to shift to the value-based model. And so we really feel strongly that now is the time for us to invest in population health management systems and to build a culture around value-based healthcare. So I want to just kind of begin by saying that in this presentation I'd like to talk a little bit about where we've been, what kind of some of the key drivers were for us to initiate this strategy, where we are right now with our population health management program, and where we think we need to go to make this a sustainable and viable program moving forward. Just a little bit about our organization. We're a for-profit healthcare system. We're owned by Ardent Health Services based out of Nashville. We have 3 divisions. Our division in Oklahoma, we have another division in New Mexico, and a 3rd division in Texas. In our market in Oklahoma, we basically have one ACO, which is a brand new ACO. It has very little impact right now in our market, and so the majority of our competitors are still right in the middle of fee-for-service healthcare as we are. The one advantage I think we have as a healthcare system is that we've been able to gain some experience with bundled payments, and our hospital systems have been involved in the ACE demonstration project over the past several years. And so we've got fairly good experience understanding how to manage cost, how to build our network of providers, and to integrate the delivery healthcare with cost containment in both a substantial number of cardiovascular and orthopedic DRGs. And we think to some degree this has given us a little bit of a leg up in terms of moving into this value-based model. Within our division, we have 2 tertiary hospitals and 4 rural hospitals, and so we kind of have a fairly broad perspective of healthcare from the hospital side. Our Utica Park Clinics has approximately 200 providers, and we have a sister organization, Oklahoma Heart, which has another 45 cardiologists, endocrinologists, cardiothoracic surgeons, sleep specialists, and mid-level providers. The thing about our organization, I think, that probably resonates with most mid-sized organizations is that we have a hodgepodge of information systems. We access a community HIE called MyHealth. We have one hospital EMR that bridges all of our hospitals, but we have 3 different EMRs in the physician group. And so one of the decisions that we made early on was that we really needed to find a population health solution that we thought would easily interface with the different electronic medical record systems that we have. We had to make a decision whether we invested a substantial amount of money to integrate our data into a clinical data warehouse and spend the next 2 to 3 years building that warehouse, or whether we found a partner that we could begin to build that information system, that database, to begin to do population health management. And we fell on Vitel as a partner primarily because of their ability to interface with any of these electronic medical record systems. One of the things I think that positions us uniquely in our market is that we have a fairly broad distribution of clinic locations. And so this is advantageous for us. We have practices scattered all through the eastern part of our state, which is our network. We have a good solid base of primary care practices, with about 70% of our physicians being primary care practices. And we have a hub and spokes model of hospitals and specialty clinics that reach out to our rural area, which again gives us the ability to go out to employers and to payers as well, and share and hopefully sell our market to these individuals. So our philosophy, being a volume-based organization, was, from the physician's perspective, do no harm to the patient, and from the healthcare system's perspective, do no harm to the healthcare system's financial health. And so we spent a substantial amount of time understanding where we can expand population health into the healthcare system, which without creating demand destruction inadvertently as we begin to navigate the waters. And so we've spent a large amount of time with our executive team trying to understand where we think we can move first and where we need to move next, and then staging our population health rollout over a period of time. Our initial implementation of a software solution for population health really didn't start as a mechanism to build a population health system. We initially began this process as a way to drive volume through a acquisition of a primary care group. We acquired a hospital in 2011, and at that time there were approximately 35 or 40 primary care physicians, and as we went through the acquisition, we understood that their productivity was not at a threshold we felt was adequate for that acquisition. And this hospital happens to be in an area that has a substantial number of primary care practices. And so rather than waiting for the next 2 to 3 years to try to drive volume in these practices by acquiring new patients, we decided to reach out with a Vitel outreach program to generate volume within the established practices already there. And we started with a pilot of approximately 60 providers, and we're very pleased with the initial outreach program, and I'll share a little bit of that information on our slides coming up. After we established our initial pilot project with the Vitel outreach program, we became a little more confident in our ability to begin to scale some of these tools, and so we brought in a consultant group with the advisory board called Southwinds to discuss the possibility of actually establishing an ACO in our market. The initial presentation was exciting, and we thought that we may be able to move in this direction. But at the same time, a CMS innovations program called the Comprehensive Primary Care Initiative was also being floated in eastern Oklahoma. And after we went through the process, we felt that the risk of financial benefits for our organization were outweighed in the CPCI program, and elected to move forward with this program. And I'll talk a little bit about how we've been able to utilize federal funding through the Comprehensive Primary Care Initiative to begin our venture into population health management. The CPCI program really has 5 core foundational tenets to its initiative: the risk stratification and empanelment process, creating access and continuity, planned care for chronic conditions, patient and caregiver engagement, and coordination of care across the medical neighborhood. And if you're familiar with the patient-centered medical home, you'll understand that these are really the core tenets of the patient-centered medical home as well. Although this initiative was really designed as a funding mechanism for care management of the high-risk patient, and not like some of the other programs we've seen, which are designed really to build a patient-centered medical home. Through this program, we had 15 of our clinics selected, which was about a quarter of the total practices in our market. We had 60 providers, and our total panel, which includes Medicare fee-for-service patients and Blue Cross Blue Shield of Oklahoma patients, is currently at about 15,000 patients. The funding mechanism for this is interesting because this is really how we've begun to look at how we'll be able to fund our population health management program moving forward. The Blue Cross Blue Shield payment was a Tier 1 payment of $28 per enrollee per month for 10% of their enrollees, which they deemed the highest risk, and then $1 per member per month for the remainder of the enrollees. On the Medicare fee-for-service payment, the average payment was about $20 per beneficiary per month for the first 2 years, and this decreases to $15 per member per month in the 3rd and 4th year. And we are in our 3rd month of year 2 for the CPCI program. But the payment is divided into quartiles based on HCC scoring. The payment is also prospective, and so we receive payment before the program begins, and then we receive a quarterly payment, which allows us to continue to fund our program without having to use our own funding. So as we looked at the comparisons between an ACO or a Medicare Share Savings Program and the CPC program, it was pretty clear that this prospective payment really placed no risk financially on the healthcare system initially. Required very little system integration initially because it was really focused on primary care practices. We were not as concerned about creating demand destruction on the hospital side as far as ER utilization or inpatient utilization, because to begin with, we could really target where we wanted to go with the program. And the requirement for network integration was fairly low compared to an ACO, which really requires the establishment of a fairly robust network. And so as we've gone through our first year of this program, we've been very pleased with the fact that we've been able to move along this trajectory of value-based purchasing beyond where we thought we would have been by this time otherwise. We've noticed that we've now embedded approximately 15 RN care coordinators into practices. We've developed a fairly robust care plan for several disease states. We feel like we've really moved forward in terms of creating a transition care program. And we hope soon to begin to see some impact in terms of cost and utilization. we think that within the next year or so, once we've been able to develop some internal reporting mechanisms, that we'll be well on our way to being able to share substantial information with payers, which we think is really the direction we need to head. We understand that in our market, as in most markets, employers are really looking for health care that provides value, and being able to share information with them regarding utilization, regarding clinical outcomes, and quality metrics is really the key for our success moving forward. So as we've gone through this whole process, I'd kind of like to summarize some of the strategies we've implemented to hopefully create some degree of sustainability in our population health management program. And these are a way that we've been able to tailor our program in a way that the impact was minimal to the healthcare system in terms of risk, and maximizing the potential for generating additional revenue while providing, what I would refer to as quality revenue, and meaning closing care gaps and generating wellness exams. So I think looking at the utilization of Phytel outreach in terms of improving productivity and improving quality metrics, one of the things that we've really struggled with as a healthcare system was that our compensation model for our providers is 100% volume-based. And so consequently, we were doing two things. We were driving volume through practices, and we were failing to share quality data with our providers. And so our providers really didn't have an understanding of what gaps of care were being missed. And to say this, some providers we don't think cared very much about identifying these gaps of care. We also were able to drive volume through practices that were not where we needed them to be from a productivity standpoint. And so those practices that access was not an issue were able to truly create additional volume by simply closing these care gaps. The outreach program also allowed us to focus on wellness exams, which we had not been particularly faithful in following through, and especially Medicare wellness exams. Up until this last year, our organization had a health plan, a Medicare Advantage plan, and that Medicare Advantage plan really keyed on HCC coding. So we spent a lot of time in the last year driving wellness exams and driving appropriate coding, and then gap closure in this population of patients. And we've been very successful. We had last year almost 80% of our Medicare Advantage patients in our owned MA plan had received Medicare wellness exams. And I don't think too many healthcare systems can claim that degree of success, and the majority of that is really driven by our outreach program. The number 2 item is tailored outreach to support clinical specialties. And so as we set up our outreach program, we really focused on areas where we had employed providers. And we've got a fairly strong gastroenterology group employed by the group. And so one of the things that we really tried to reach out was our colon cancer screening. We know that that our colon cancer screening rates were lower than we would like, based on our internal data and based on data that came from our Medicare Advantage plans. And so we really focused our outreach on colon cancer screening, mammography screening. And so those were areas that we thought drove appropriate volume and revenue into the organization. We also looked at how we support our hospital-based services, and items such as mammography and DEXA scanning were areas that we really targeted our outreach as well. As part of the CPC program, we're required to support clinical metrics, and so we couldn't have done this CPC program without some sort of a database. And so the FITEL Outreach and FITEL Insight both provided the support for that data reporting. One of the things that was required as part of the CPC program was the ability to impanel a practice. And despite the fact that we think we do a pretty good job on the front end of registration, identifying who the patient perceives as their primary care provider, when we began to look at the information in FITEL after it was appropriately mapped, we understood that we probably only collected 60 to 70% of the patient's primary care provider data. The nice thing about the FITEL product is that they create two fields. One is called a FITEL assigned, and the other one is called the provider assigned group. And so when a organization doesn't have an assigned primary care provider, FITEL can run an algorithm and determine who they think is the primary care provider for that patient, and then create that panel. And so this allowed our staff to then go back and clean up our registration process and to identify who the patient's true primary care provider was. And then this allows our physicians to begin to understand the concept of taking care of a population of patients or a panel of patients. And so this support, although not anticipated, turned out to be a real key metric in our CPC milestones, and allowed our physicians to better understand who they're really taking care of. The patient-centered medical home project also included leadership development, and so one of the things, although perhaps not a financial driver for the organization, we made a philosophical decision that we were not going to place the burden of this population health management development on the providers. And so we've trained our administrative staff and our care management staff in process improvement, and we've created a great partnership with FITEL in terms of utilizing their internal resources with Jerry Green and his team to teach Lean Six Sigma tools to our employees. And thus far, all of our administrative staff and almost all of our care managers are Blue Belt Lean Six Sigma trained, and we are beginning the process of selecting a handful of staff that are going to be Green Belt trained. And this leadership training was way beyond process improvement. It really gave our staff the confidence to go into a practice and help them understand how to improve processes, how to lean out their workflows, and to improve the quality of care provided in practices. And this, again, allowed the physicians to continue to see patients and provide care without trying to juggle between changing the culture of their organization and providing care to the patients at the same time. In addition, we understand that Medicare's payment mechanisms are going to be changing in 2016, and our value-based purchasing requirements require some lead time. And so we feel that we've got a good 12 to 18 months lead time on building our quality metrics, improving our processes, and hopefully being in a position by the time that our value-based purchasing arrangements have been made with our payment methodologies, that we'll be able to capture additional revenue on the group side. Looking at other opportunities to pay for our population health program, the transitions of care infrastructure has been a major effort from day one. We currently have budgeted 4 full-time positions for RN care coordinators in the hospital that work specifically with our group's patients to assist with the transitions of care. And they'll continue to follow those patients with specific DRGs, including congestive heart failure, the acute MI, and pneumonia DRGs. And they'll follow those DRGs for 30 days post-discharge. The the benefit of this is that we think that the hospital can substantially lower their risk of readmissions penalties, and at the same time focus on those high-risk populations of patients. The fact is that we have approximately a $1.5 million risk for readmissions penalties this year, and this increases to $2.5 million next year. And if we can simply decrease or eliminate the readmissions penalties, this alone will pay for our population health management program. We know that pay for reporting is part of several of our contracts right now, and in our organization, any of the pay for quality metrics or the PV, PQRS monies that will come into the group are taken in to the group and not shared with providers. We have a separate compensation model which we will slowly begin to transition to a value-based model, but currently it's an RVU-based model. And so what we've done is we've taken some of this revenue that comes from the pay for quality measures, and we use this to offset some of our costs for our program. Really the next piece of this is this fact that we understand that it takes about 1 to 2 years to really build the infrastructure for care coordination and population health management. And the fact is that we need to have automation in place to make sure that we have the ability to manage these high-risk patients in an efficient way, in a lean way. And so having the Insight Coordinate tools and looking forward to some of the newer tools that are being developed through Pytel helps us become much more confident that we'll be able to scale these products out to a larger population of patients and begin to do this with as much automation as possible, and hopefully allowing us to target those high-risk patients more efficiently. And then the last piece, and I'll talk about this a little bit later, is really focusing on our employer-based population health. We understand that employers are very concerned about whether or not healthcare systems really truly want to partner with them to help lower their costs. And one thing we can share with them is that we've got data now to support that we can improve the quality of the care that their employees receive, and that we can do this in a more cost-effective manner. And this reassures them and hopefully alleviates some of that anxiety that the healthcare systems will continue to run volume through the organization to maximize their own revenue. And so we've shared a lot of information with the employers that we've partnered with, and they've been very excited to understand and see how some of our tools are working. So just as a quick overview, our outreach program after our first year generated almost 300,000 communications, which were all automated communications, and this includes reminder calls for visits and outreach calls for gaps in care. Almost 65,000 patients were informed of care gaps, and almost 7,000 patients we can track directly to an office visit through this program. And this was just with our first 60 provider pilot group. We've now rolled the outreach program out to all of our primary care practices, and as other organizations have demonstrated, that we've had basically a fairly solid return on our investment depending on how we measure those metrics. We think that looking at the measures and looking at the adherence revenue to those gaps in care and closing those gaps in care basically pays for our outreach program and probably pays for a substantial portion of our population health management tools with our Insight program. And so in a way, just initiating the outreach programs can generate its own funding stream. One thing that we were very pleased with is looking at adherence rates. And so as we go out and we talk to our providers about those high-risk patients, one of the things we continually hear is these are the people who just don't respond. These are the people who aren't willing to do the things that we ask them to do. But when we look at adherence rates to our outreach phone calls, it's our high-risk patients that seem to be the most responsive to these programs. The fact of the matter is that they are just waiting for someone to demonstrate an interest in helping provide care to them. And so our poorly controlled diabetic patients seem to be the ones that have responded the best to our outreach programs. I wanted to share just a little bit about what our current outreach protocols are. The one thing we've been really pleased about is that when we implement outreach protocols, we've been able to go back and modify these protocols based on feedback from our providers, based on feedback from the patients, and we've been able to tailor the program in a way that really was more consistent with what our practices thought was appropriate for patients. We are now beginning to look at outreach protocols for specialty services, and we'll begin to expand some of these protocols. We've been so pleased with the Medicare wellness outreach that we've expanded this to subsequent Medicare wellness exams as well. In addition to our outreach, then, the requirement of population health is that we have to have care managers in the practices, and so we've embedded approximately 14 RN care managers into our practices. And I would say from experience, our market really did not have a surplus of RN care managers looking for jobs. We've taken nurses from all aspects of the healthcare world and begun to train them and get them prepared to do something that many of them had never done before, which was provide care management to high-risk patients. And so it's taken us a full year and probably 3 months to develop the complement of care managers we need for our practices. Now we're beginning to look at a second layer of medical assistants or LPNs to do a lot of the phone follow-up of these patients. We have 4 hospital transition of care nurses. We have 2 current and 2 budgeted that we're trying to fill. We've added 2 social workers and understand that at this workload we'll probably need to add a 3rd social worker. We have diabetic educators. We've added a health education specialist who also works with employers in our business development process. We've added a full-time clinical data analyst and then 2 additional support staff. So at this point in time, we're at about 27 FTEs. And although we're applying a lot of the budget-related activities to our 15,000 CPC practices, we basically have begun to expand this to all the members of each of the practices. Moving into the business world, we have spent a lot of time talking to employers, and employers understand that they have to find a solution for their costs. We've seen situations where their costs have gone up 3- and 4-fold with almost no improvement in outcomes, employment, or employee absenteeism, and I think that employers are very frustrated with their partners on the healthcare side. And what we've begun to do is work with employers to help them understand the different opportunities that we can grow market share and that they can lower their global cost. The bundled payment model is helpful, and as we've spent time with employers, they are very excited about bundling payments or discounting their inpatient fee schedule. But employers understand that we can continue to drive volume through a healthcare system and continue to drive their cost up. And as I mentioned before, being able to include into this improved access, chronic care management, quality metrics, health maintenance, these type of opportunities, we think that employers will begin to understand the value of partnering with an organization that has a robust population management program. And as we provide these services, we think that we can grow market share by expanding into markets that we've not been part of in the past. And so we began to look at this model initially as a generic model where a company decides to either becomes self-funded, directly contract, or create some sort of a narrow network. And we began to understand the components, the third-party administrators that process the claims, the provider networks, the brokers, all these components of this process. And we began to reach out to these individuals and begin to build relationships. And so as the medical director for the healthcare system, I've spent much more time in meetings with brokers and with TPAs than I ever imagined I would, simply trying to help them understand what population health management looks like and try to understand what we're accomplishing on the group side. As we've paired that up with this kind of hospital rates and bundled payments, we really feel like we can create some claims data which supports some shared savings opportunities. And we understand that on the employer side, it's 50% of their claims costs are outpatient. It's not just the inpatient costs that they're focused on. And in addition to that, one thing we've really focused on is the fact that between 40 and 70% of employees do not have a self-identified primary care physician. And this fact alone is a great opportunity for a group that has such a solid core of primary care practices. So as we have these conversations, what we hear is that providers want to, that employers want to lower their medical costs, but they want to improve the quality of their care as well. And wellness and health risk assessments are part of this. They want to see evidence that chronic disease states are managed because they understand that that's what's driving their expense. And then they want to really make sure that their employees have that PCP associated with them so that at 10 o'clock at night they can make that phone call and obtain therapy or recommendation rather than going to the emergency room when they're ill. They want to see that the patient's employees are happy with the care they receive, and they're trying to avoid that managed care model from the 1990s where there was a revolution against managed care because it was deemed to be the evil empire. They want to make sure that that the time away from work is limited, and we focused on near-site opportunities for practices, and that they can partner with organizations that provide things like occupational health and rehabilitation, which in a healthcare system like ours is kind of our core business. So we've looked at hospital pricing. We've talked a little bit about near-site clinic access, and so as we have conversations with employers, we identify those practices that are the closest, and we bring the employers into those practices and have lunch with the physicians, with the managers, and with our management team to help build those relationships. We've discussed on-site opportunities such as wellness screenings and immunizations. And we've talked about providing additional educational content. And one thing we hear over and over is that providing content and opportunities to improve the medical knowledge of their employees can greatly improve their satisfaction with the care they receive, which is one of the reasons why we brought on an educational specialist to work directly with the employers. And so we look at creating a a la carte list of services we can offer to employers, which I think provides a great opportunity for them to tailor the products that we provide them. And this is an example of a webinar that we provided to a healthcare system and talking about weight management strategies. We've created multiple videos that are online that are 3 to 5 minute videos on health-related topics. And so I think that it's nice to kind of look at this evolution of partnership as we progress from building the liaison relationships to looking at how to tailor the network to drive volume into our practices, to provide the on-site care, and then eventually we'd like to get to the point where we are doing more analysis of claims data and creating additional benefits for the organizations. And so our next steps is really to hopefully build an analytical database that we can create focused and targeted care management to those patients that are the drivers of cost, and also to tailor additional educational and outreach tools to the employees as really dictated by where the cost is being driven. So understanding, the population, what their costs are, who the high-risk patients are, this is integral to population management, but it's also kind of the core of what employers are trying to understand. And as we visit with employers, we really love to share live screenshots of our care coordination tools, and this is a diabetes by A1C, which each one of these bullet points represents a single patient. And the color looks at the number of care opportunities. And so as they see this real-time feed, they're very excited to move along this path with us. We like to look at how we can filter their employees by the payer type, and how we can create content and outreach by email to employers. And here's some examples of content we created targeted to our Tulsa firefighters group because of the concern of the amount of sleep apnea that these firefighters were suffering with. And so this is an outreach we generated to them. In addition, here's some targeted outreach for influenza vaccinations to the Tulsa Teachers Credit Union. And we can generate 40 or 50,000 emails with a click, which again is an efficient utilization of our resources. And then sharing how we can drive the metrics on the quality side down over time is really exciting for the employers. So our first 10 months of this, we've brought in approximately 6,000 new potential patients into our practice. And these are some of the organizations that we're working with and continue to work with. So one of the nice opportunities we've had with FITEL is to be able to create this process of educating our staff on Lean Six Sigma processes and building some of the infrastructure that's required to provide robust care management. And we really spent a lot of time on process mapping and understanding workflows around our practice. And it's been very eye-opening for our staff members when they've looked at the complexity of moving a patient from check-in to check-out on a single office visit. And we've really been able to improve some of the processes within our practice, and we continue to look at process after process as we've understood how to process map and how to understand to change our processes within a group. And again, the importance of learning how to collaborate with our teams, and that culture within a practice that moving from the doctor as the captain of the ship to the doctor as an important and integral member of the team is really a shift that takes time, and we continue to work on that, but we've made a lot of strides in 1 year. And so here's some examples of our group sitting down, going through process maps, and understanding how this is done. And you can see some of the FITEL team members who are leading our process mapping training programs. And we've sent employees down to FITEL to do the training, and we've had the staff come to our locations to do some training as well. And here's a picture of one of our processes that I think was our physician recruitment process. And when we finished this process map, we really wondered how we ever recruited a physician in the organization because of the complexities of all the different steps. But somehow we managed to get through it, but we've also identified the ways that we can improve these processes. So that's really a kind of a nice, quick summary of what we have done and where we plan to go. Obviously, moving in the direction of population health management is the future for our organization, and we understand that that everyone is looking at this. But I think the sooner an organization can get started on this path, the sooner they can understand the daunting task that it is, and the sooner that they can move forward with this and become successful with this. So with that, I will return it back to Guy for additional comments.
Great. Thank you, Dr. Gallup. That was fantastic. You've done an excellent job of highlighting a number of different areas that provider groups and health systems can take today to really shift towards coexisting in both a value-based environment and a fee-for-service environment while funding the transition. So fantastic work, and I commend you and your team and Utica Park's efforts. Fantastic. At this point, we'll go ahead and begin to take questions, so feel free to submit those questions online using the question chat area of the GoToWebinar controls, and we've got some questions coming in as we go. One of the areas you spoke about was the medical home, and many organizations are looking towards PCMH as a provider-led delivery model that really starts to employ population health approaches to care. And while PCMH pilots and peer review evaluations have shown cost savings and utilization reductions, and payers and health plans continue to fund and sponsor that model, we did see a recent study last month from JAMA indicating a little bit different results and almost a surprising conclusion that PCMH had nominal impact on quality and cost. And I know we spoke about this before the webinar, but do you mind speaking just a few minutes on the cultural aspects of PCMH that were important to Utica Park and what you've seen with that transformation process?
You bet. So not to step on the NCQA's toes in terms of patient-centered medical home certification, I think there's great value in going through a certification process to build the infrastructure. But the fact of the matter is that the culture is really, truly the key driver to the success of a population health management program. And if you can't shift the culture of a practice or an organization in that direction of value, then it's going to be very difficult to cost shift or to bend that cost curve. And so from the perspective of our practice, we know this takes a long time, and we have some providers that may never get there. But as an organization, when each of the providers begins to see progress and begins to get that feedback from patients about how they value the care and the outreach, then it begins to shift the culture slowly but surely. And so I think one of the things that I read into that article in JAMA was that they went through the certification process, but they really don't address the notion of, was the culture of the organization really changed? And I think, what we measure on a regular basis in our practices is what's the feedback and how do the providers view this? And as the providers begin to buy into the concept of value-based care, I think that culture begins to shift. And I think that's where you'll really see the true value. The other perspective of this I think that is important is that as we implemented outreach in our practices, we probably drove up cost because we were capturing patients that had not had screening studies that needed to be done. And so initially, we may actually increase our costs across the organization, but as we begin to stabilize that population of patients, I think that's when we'll begin to see the costs go down.
Very helpful. There are a number of questions in terms of the panel size of patients. I think you indicated 15,000 patients, and the questions were relating to the number of care managers, number of PCPs those patients were divided between or across. Can you talk a little bit about the staffing for those 15,000 and what the care management work structure would look like?
Yeah, and so one of the things that we really focused on is risk stratifying our patients. We created our own risk stratification tool internally, but the risk stratification, as anyone knows, is kind of a complex process, and validating risk stratification is really even more complicated. And so our first pass was really the general gestalt of the provider, of the wellness of that patient, and we created 4 risk stratification levels. What it boils down to is that of our 15,000 patients, we think about 10% of them really qualify for what we would consider high-risk care management, and we think that the average care manager can manage about 150 high-risk patients. The problem is that we don't have care managers that are well-oiled machines and have a 10-year history of providing care management. And so right now our care managers are probably not as efficient as we expect them to be moving forward. But we think if we can get our care manager to manage between 100 and 150 high-risk patients, and we assume that about 10% of our population will be high risk, that's really how we begin to budget the need for how many care managers we will need. Now, over time, we're going to fine-tune this based on feedback from our care managers, but this is part of the learning experience. Part of the learning experience is really gathering this data, gathering the information from the care managers, and understanding, is this a viable assumption or not? And we're still early into this project, and so we're still learning.
Great. Thank you very much. Appreciate that. Let's see. There's a ton of questions coming in, so feel free to submit as we go here, and we'll, like we indicated at the beginning of the presentation, we'll try to respond as many as we can right now, and then we'll respond after our time is up. What factors were looked at when you looked at the risk stratification? Is there any algorithms or process steps that you can share in that risk stratification?
You bet. So we looked at some of the national standards, some of the national tools that are out there, and one of the things that we heard over and over was the most important way of risk stratification was what does the provider think of the severity of illness of a patient, and so we really kind of focused on that general question, would you be surprised if this patient died in the next 1 year? And if the answer was yes to that, or if the answer was no, I wouldn't have been surprised, sorry, then we really deemed that person a high-risk patient. We looked at age, we looked at number of medications, we looked at a number of emergency room visits or hospitalizations, but ultimately what it boiled down to is that the provider's general gestalt of the patient was the most significant. Also understanding that the majority of our patients are going to be low risk. 50+% are still going to be based on their current clinical status are going to be considered low risk. I will say this: we've worked with a project in a project with Fitel to try to figure out if there's a way that we can automate this process through the data that Fitel gathers, and we're real excited about moving forward with an automated strategy through Fitel, considering the fact that they have so much of our data as it is. As we begin to feed information about admissions and about emergency room visits through our transitions program, we think we can paint a pretty good picture of what that risk stratification will be based on the data that Fitel already carries. And we're excited to look at their automated process and compare how Fitel is going to automate risk stratification and how that compares to our internal benchmark.
Excellent. Next question. You mentioned ED visits and inpatient admissions being part of a health system. Can you talk a little bit about what impact you've seen on the hospital admissions or ED visits and what impact that's had within the organization?
Yeah. And so we really focused primarily on readmissions. So the ED transitions of care has been something that we're planning on implementing. And so just as a look into the future, we're beginning to look at our transitions automated phone calls through Fitel for our ER visits. And rather than plugging those transition calls into our own EMR, which really captures probably about 70% of our ER visits, what we're trying to do is build a relationship with our community HIE so that we can gather ED visits and hospital admission data from all of the competing hospitals in our market and give us that 360-degree view of our population of patients. So moving forward, we really want to get a better view of what that emergency room visit and that transitions of care and readmission process looks like from that perspective. One thing, though, that's really important to understand is that as you begin to look at lowering readmissions, it is a slow process. It's taken us a year to begin to even notice a change in our readmission rates, but we're beginning to see a decline in readmission rates, primarily in our congestive heart failure patients and our pneumonia and COPD patients. We've still struggled a little bit with acute MI because there's so many nuances to, was it an MI, was it not an MI, and so much depends on your certified coders and how they interpret information. And so we've still struggled with this, but we begin to develop, I think, some evidence now that our readmission rates have gone down in those two other categories. And I think, if you'll ask me a year from now, I think we'll be very successful in terms of building those relationships. But we've really begun to build that partnership between care coordination in the hospital setting and then care coordination in the office setting. And I would say if you want to focus any efforts, it's medication reconciliation, which is where the money is. And we've spent a lot of time working on medication reconciliation before the patient leaves the hospital, and then building that follow-up visit within the next 7 to 14 days. And another source of revenue for the group was the TCM codes on our transition of care. And so we've found a substantial increase in our TCM codes over the last 6 months because of that transitions of care process.
Excellent. Next question has to do with the cultural shift towards population health. How long would you say it takes for a practice to really understand the nuances of population health, or to really understand that transition, really what that means to them and their organization and their patients? How long do you think it takes typically to go through that?
I'll let you know when we get there. I'm being a little facetious, but it varies from practice to practice, and we've got 50 different locations, and each practice kind of has its own culture driven by the strength of the personalities and the experience that the providers have. And so some providers have really, truly fought the transition, and some providers have engaged this. And so we've really focused our time and our efforts on the practices that have engaged this cultural change. And then we begin, as that's happened, it's taken us about 15 months for some practices. Those practices that were really bought into it, we see that in 15 months they've really, really begun to engage the process. We have some practices that are a long ways away, but it's interesting, and I'll give one example. We had one physician who really was not interested in moving in this direction. And we pushed and we pushed and we pushed on colon cancer screening because his practice had some of the lowest colon cancer screening rates in our organization. And so, lo and behold, one of the patients that we screened ended up having substantial stage 4 colon cancer. And one of the things that we brought up to him, after this was all done, was that, if you had implemented this process 2 years ago or 3 years ago, this patient may have been in a position where they were curable. And I think that really resonated with this provider. And I think we saw almost an immediate shift in terms of his buy-in to the whole concept of population management. And so for some people, it really is a eureka moment. In others, it's just a gradual change over time. And as I mentioned before, we may have some providers that never make that transition. And so we have to make a decision in the long run whether that provider fits the goals of our organization.
Excellent. We are just about out of time. I'm going to go ahead and give one more question. I did indicate that the slides will be shared for folks who are asking. We will be following up on every question, regardless if it's answered online or not. Lastly, the final question is, you indicated about 100 patients per care case manager. Is that the maximum capacity, or what do you see over time with that ratio, one care manager to 100 patients, high-risk patients?
Yeah. Well, I think as the care managers begin to develop workflow and begin to develop some tools within the care management suite, I think that we'll see efficiencies improve. And so one thing I wanted to say is that we've been working with Phytel on an evolution of their care management suite called Nightingale, which we're very excited about piloting. And I think that having the right tools in the care manager's hands can markedly improve their efficiency. The other piece of this is that as we begin the whole process of care management, every patient is like a new patient to a practice. They're labor intensive and they're really time intensive. And so As we build those relationships, and as those care managers identify gaps and barriers in the patient's ability to be fully engaged, we begin to see that the efficiencies improve. And so we think that right now 60 to 70 high-risk patients is a full hand for our care managers, but we really believe that we can get up to about 150 if we're able to provide some level of support, and this includes, perhaps adding a data analyst or adding a medical assistant who can then make additional phone calls and simple follow-up, because the RN care managers really like to spend time with the patients and do a lot of teaching and education. The other component of this is that we've really begun to develop a suite of educational videos and shared decision-making tools that we've been able to fund through our CPCI funding. And so being able to provide some of these tools online to our patients and being able to drive some of these to our patient portal, we think will really improve the efficiencies of our staff as well. And so for those patients who have really targeted needs, for example, how to use an insulin pen or how to check a fingertip blood sugar, those simple components we can automate by just simply linking them into online videos and educational tools. So I think there's a lot of different ways of improving the efficiencies of our care managers, and we listen to them. We spend a lot of time coordinating our activities and trying to understand what it is that they need to support their goals. And so with that being said, I think that our care coordinators will continue to be more and more efficient over time.
Excellent. Very good. Well, I'd like to thank you, Dr. Gallus, and Utica Park, Hillcrest, and Ardent Health Services for donating your time today. This has been highly insightful, and I appreciate the time you put into the presentation. At this point, the webcast has ended. Thank you for all attending, and have a fantastic day.